Hello and welcome everyone. It is 12:15 and time for us to start our ETSU VMAT Echo session for today. It's good to have all of you here with us. I'm Joyce Troxler, your facilitator. My background's in family medicine and addiction medicine, and we are bustling to finish up our clinic from this morning. So if any of us seem a little half put together, that might be why. We're going to start with some introductions like we normally do, and then roll into our didactic session brought to us today by Kamran, Hayel, and Mina McVeigh. And then I get to do our case this afternoon. So we'll roll through that, and all questions, thoughts, perceptions, whatever you want to bring up, please do. Meredith, if we can get started with you, please unmute and introduce.
Hi, my name is Meredith Kinley. I'm a licensed clinical psychologist and assistant professor at ETSU.
Great, thank you, Meredith. Kamran, if you can go ahead and unmute and introduce.
Hi, my name is Kamran Hayel. You don't need to.
Go ahead and get that technical issue taken care of early and in the beginning.
Living in the same, you just have to stop your microphone.
I did.
And stop your speaker. Silent your speaker. Yeah.
I think we might be good now, Kamran.
I think it's good right now.
Yep.
Hayel, I'm a psychiatrist, addictionologist, and associate professor, associate program director.
Beautiful, thank you, Kamran. Brian, if you can unmute and introduce.
Hi, I'm Brian Clark. I'm the technology coordinator at ETSU CME. If you have any technology issues during this call, you can connect with me via chat, and my phone number is in the participants list.
Fabulous, thank you, Brian. Michael, if you can unmute and introduce.
I'm Michael Mishka. I'm a psychologist and clinical director for behavioral health operations at TenCare here in Nashville.
Fabulous, thank you, Michael. Katie, if you can unmute and introduce, please.
Hi, my name is Katie Langley. I'm in the ETSU Psychiatric Nurse Practitioner DNP program.
Great, thank you, Katie. It may be mine isn't turned up enough, but I could barely hear you. So I'm turning up my volume, Katie, but we'll make certain if others other than me are having a hard time with Katie, we'll see if we can troubleshoot that in a little bit. Okay, it was quiet on other people's end too, Katie. So just an FYI.
I was using headphones. Is this better?
It's a little bit better, but it's still a little hard to hear you. We can get it sorted, and always we have chat. So even though I like hearing your voice directly, if you're trying to talk to us and we aren't acknowledging you, you just put it in chat for us, okay? Beautiful. Tanya, if you can unmute and introduce, please.
Hi, I am Tanya Milam, and I'm with the Addiction Medicine Fellowship here at ETSU Family Medicine. And Skylar is behind me.
Hi, I'm Skylar Geller. I'm an addiction medicine fellow at ETSU.
Fabulous, thank you. Debbie, if you can unmute and introduce, please.
Good morning. My name is Debbie Hillen. I'm a licensed alcohol and drug counselor and qualified clinical supervisor, and I'm with Buffalo Valley.
Beautiful. It's good to have you, Debbie. Thank you so much for joining us. Mina, if you can unmute and introduce.
You don't have to.
Hi, I'm Mina McVeigh. Mina McVeigh, and I am the licensed clinical social worker here at the ETSU Addiction Medicine Fellowship.
Beautiful. Thank you, Mina. Veronica, if you can unmute and introduce.
Hi, my name is Veronica Van Ray, and I'm a certified peer recovery specialist and bachelor's of social work here at ETSU Family Medicine Addiction Medicine Fellowship.
Great. Thank you, Veronica. Brooke, if you can unmute and introduce.
Hey guys, I'm Brooke Claiborne. I am the behavioral health SUD and my case manager, addiction counseling grad student, and I recently found out that I was awarded through the MBCC Foundation the Addiction Counseling Fellowship for this next year.
Oh my goodness, because you didn't have enough stuff going on already, Brooke. That's fabulous. If you need a support group for helping you manage all the things that you do, we could probably have a spin off of this Echo for that. Simona, if you can unmute and introduce, please.
Hi, everyone. I'm Simona. I'm one of the addiction medicine fellows here at East Tennessee State University.
Great, thank you, Simona. Rick, sir, you're up just as you take a sip. Perfect timing.
Hey, everybody. I'm Rick. Rick Wallace. I'm a medical librarian here at the College of Medicine and on the hub team.
Fabulous. Thank you, sir. Kelly, if you can unmute and introduce.
Hi, I'm Kelly Moore. I'm an assistant professor in the psychology department at ETSU and a licensed psychologist.
Thank you, Kelly. Kelsey, if you can unmute and introduce.
Hey, my name is Kelsey Wallace. I'm a nurse practitioner. I work on the Help Sarah grant in the College of Nursing, and I'm starting a psych program in June.
Great. Thank you so much, Kelsey, and congratulations on that. That's exciting. Next up, actually, the auto LTC NU42 and a bunch of other numbers. That's our Norton Community Hospital Internal Medicine Residency Program over in Norton, Virginia. Again, joining us. Thank you guys for joining with multiple students and residents. And because I think they have a room full, they will be using chat to communicate with us. And Katie went ahead and added, just because we couldn't hear her very well. Thank you, Katie, for doing that. She's a student at the ETSU Psychiatric Mental Health Nurse Practitioner and Doctor of Nurse Practitioner programs. So thank you. The chat really works. If all else fails, chat. K-Ball 8, if you can unmute and introduce, please.
Hi, I'm K-Ball. I am a nurse case manager with United Healthcare Tencare.
Fabulous. Thank you so much for joining us. I think you've been with us before, so it's good to have you again.
Thank you.
You're welcome. Judy, if you can unmute and introduce, please.
Hello, I'm Judy Waldrop. I'm a psychiatric nurse practitioner, and I'm so excited to be here.
We are very happy to have you with us again, Judy. Thank you for joining. Keith, if you can unmute and introduce, please.
Yeah, I'm Keith Hefner, Behavioral Health Case Manager with United Healthcare.
Wonderful. It's good to have you. We have such lovely, broad, diverse representation on these ECHO sessions. I really appreciate everyone showing up and representing your area of the field. Thank you. Amanda, if you can unmute and introduce, please.
Hi, my name is Amanda McCurry. I am a family nurse practitioner resident with ETSU.
Great. Thank you so much, Amanda. And Sudha, it's your turn, please, ma'am, if you can unmute and introduce.
Hi, I'm Sudha Kumar, and I am also the family nurse practitioner resident currently at Johnson City Community Health Center.
Beautiful. Thank you for being here with us, Sudha. And then Suzanne, if you can unmute and introduce, please.
Hi, I'm Dr. Suzanne Fletcher. I'm from Nashville, Tennessee, and I'm in a private practice, addiction specialist private practice with my son.
Wonderful. We need to get your son on here. He's probably busy seeing patients, but maybe one day you can get him to do a cameo appearance. We'd love to meet him as well. Thank you for joining us. All right. I don't have any announcements for today other than we will be having, it is an addiction medicine filled ECHO session for you guys. You're going to get a belly full of us today because Kamran and Mina have our presentation, and then I'll be presenting a patient to you after we've gone through their presentation related to ADD and substance use disorder, that overlap, and then I'll have a case for you guys. Kamran and Mina, it is all yours.
Thank you. And let's see if you can see the screen.
Yes.
Okay. Well, we are talking about the ADHD, persistent pattern of the inattention and or hyperactivity impulsivity that interferes with the functions or development as characterized by either inattention and or hyperactivity impulsivity. So before we start that, let's see. Back and forth. This is our disclaimer. We don't have any financial disclosure to reveal. And therefore, now if you're looking at the population survey, suggests that the ADHD occurs in almost 5% of the children and 2.5% of the adult. These two numbers is very important to remember because in the future of this presentation, we would come with the different number among the people that they are using the substance use. I borrowed this one from the diagnostic manual, DSM-5, and I'm not going to read through all of them, but 6 of the symptoms for at least 6 months among the people younger than 17 is required for the inattention to make the diagnosis. And when is someone older than 17, then 5 would be enough. It's very important to look at those examples that they are saying here. Overlooks of or misses the detail, the person has difficulty remaining focused during a task. It seems like that their minds is somewhere else and they are easily distracted. They have to lose the focus when they are starting some task. That would be inattention. They are a little bit disorganized when you see they are a little bit messy when you see in their school or any places. But one of the things that is very important is this is not happening in one setting. It does happen in school, in a home, in any other setting that they are living in. It's not related to one setting. You do have access to these slides later, and you do have access to the DSM-5. Certainly you can pick up all those criteria, but there are 9 of them. 6 would be enough for 6 months. Now there is an impulsivity part that also has the same requirements, 6 for 6 months, and younger than 17 and older than 17 needs to have at least 5 of them. And this is a little bit more observational when you see the patient. They are not able to, seems like that sitting in a seat comfortably. They are fidgety, and they have a tendency to complete your sentence. Before the question comes, that sometimes they come up with the answer, and that would put them in a difficult situation, especially if they are in the process of finding a job or doing a job, or as you may see that sometimes, people that they are a user of the substance, they get in trouble with the legal system. This particular part of the ADHD would come against them if they are in a court and they are trying to convince that they are innocent, and they will find guilty because of the interruption that they make in the court, for example. So it's very important to remember those presentation of the impulsivity on a patient that does have a ADHD. Now, it does not require to have both of them. So it can be, one or others or both of them in the same time. But one thing that I highlighted in this next screen is symptoms. It's not easy to diagnose the ADHD because you have to really rule out several other psychiatric disease too. So some of those symptoms should not only happen when the patient has the schizophrenia or mood disorder or dissociative disorder, personality disorder, or during the substance intoxication or withdrawal. You may have some of those symptoms, but it doesn't last the period of time. And also with the treatment of some of those long-time and chronic psychiatric disorder, those symptoms disappear. That means that the ADHD needs to also include ruling out other psychiatric problems. So it's not an easy task to diagnose the ADHD. And the incidents usually start in earlier age, but it's not unusual to see some cases that we don't have too much of the information about their childhood. And it's hard sometimes to collect those information from the collateral that we can have access to. But we know that it does interfere with the social, academic, and occupational functioning. So we need to have that criteria. If it's a combined, we usually specify in the diagnosis that it's a combined both inattention and also impulsivity. And we can have one is more predominant compared to the other one, and that can be specified. It can be, in a partial remission, and always have a mild and moderate and severe in a diagnostic process when you make a diagnosis. Now, look at the differential diagnosis. It's not that much easy to go through this list, and this is only a small list of this differential diagnosis, but you can see the mood disorder, personality disorder, psychotic disorder, neurocognitive disorder, and the substance use disorder are included. We have the autism spectrum also. It's a developmental disease that you can see. Intellectual disability, those are the one that it's hard to recognize sometimes. And a specific learning disorder that you will see those symptoms sometimes. It happens only at school, but when the patient and or the kids is at home, they don't have the same kind of the inattention. It can be a specific learning disorder. And so it's not that much easy to diagnose, but it's very important to keep in mind that there is a diagnosis of the ADHD exists. Now we go to the screening and testing, and I will let Mina take over, and you can use my mic.
Okay, and thank you, Cameron, for that review. And I'm going to let you move my slides along for me since you have the presentation pulled up. So screening and testing, we use the adult ADHD self-report scale symptom checklist here in our clinic. And you can see the sensitivity and specificity there. What's interesting about this self-report scale, I administered one today, is that it's slightly better, the specificity is slightly better for alcohol use disorder than other substance use disorders, but not by far. It's still a decent screen to use in the primary care setting. It doesn't take very long at all. But one thing that's very interesting is that the results, it really doesn't matter whether you do it on admission or 2 or several weeks later. We don't usually do it at the beginning, but there was the research shows that the results that you get on this particular symptom checklist are valid even if you do it when they first come in. And I actually wasn't aware of that until I did the research for this presentation. You can also use the Connors Adult ADHD Rating Scale. It's much longer and takes a lot more time. We don't use it here, but I wanted you to have that. And then you can always refer patients for additional psychoeducational testing. The challenge for that is that most insurances don't pay for adult psychoeducational testing, and they may or may not have been tested in as a child. And that's usually our experience here, is we're dealing with undiagnosed adult ADHD, probably had it as a child, but never got the appropriate attention. So we use, as I said here, the symptom checklist with a little bit of a history. And if we have any doubt, we can refer them. Here at ETSU, we have a fairly inexpensive way to test. So, okay, Cameron? Here's an example of the first few questions. Cameron put this slide in there on the ADHD screening tool that we use. So we'll just move that along. But most importantly, I think the goal that I have for this portion of the presentation is for you to understand the prevalence of ADHD in our substance using population. There's quite an interplay of mental health disorders, as we all know, in general. And so, 80% of ADHD adults already have some comorbid psychiatric disorder, whether it's mood, anxiety, substance use, or personality disorder. So you can see that there's something going on there. 34% of those with treatment-resistant depression met the criteria for ADHD. So you can see the interplay there. But in the substance use disorder population, the prevalence of ADHD, as discovered in a very large meta-analysis, is 23%. So almost, a quarter of the patients that we see are likely to have ADHD. Back up just for a second. There's a slight decrease in the prevalence in primary cocaine use disorder. It's very interesting. But with those with ADHD that are using stimulants, especially cocaine, the methylphenidate did decrease cocaine use. I just wanted to throw that in there because I thought that was interesting. So, okay, next slide. All right, so there's a huge burden of comorbid ADHD in our population. First of all, these patients tend to have an earlier onset of substance use disorder. And we know that they begin to self-medicate early for the stress of not being able, to do what they need to do in school or at home, the problems that we're having. They have a higher rate of polysubstance use. They have an increased suicide rate. People with ADHD often have a whole host of negative cognitions. They beat themselves up over their inability to perform. They have a lot of low self-esteem. They are less likely to adhere to treatment, which makes sense. If they can't pay attention, they're not very organized. Adhering to treatment is difficult for them. And that's probably why they have a lower likelihood of achieving abstinence. And their course of substance use is often more severe. So conceptualizing ADHD, we talked about what the criteria are, but it's really helpful when you're working with patients to have a broad view of what ADHD is. And really what it is a disorder of self-regulation. And, you know, think of it as a person says, I just can't do what I want to do. I want to adhere to my treatment, for example, but I just can't remember to do what you've asked me to do. They can't turn their intentions into actions. Or they have a problem with feeling like doing anything at all. There's a big motivational component. And so when you don't feel like doing anything, it's hard to get motivated. We know that this is caused by a deficit in executive functioning and reward processing, such that people with ADHD have a preference for immediate versus delayed rewards. It's really, really hard for them to push through the boring parts or difficult parts of any project, whether that's making a meal, completing a homework assignment. It really doesn't matter. And the thought is that they have a dopamine deficit, that they have fewer receptors and fewer dopamine available in order to give themselves what I consider to be like the little mini rewards that you have to get to go from A to Z in a project. Because of these deficits, they have a hard time solving problems. They don't goal set well. They tend to overuse escape and avoidance coping, that I just can't, or I'm not going to, I don't feel like it, it's too hard, it's someone else's fault. They have a lot of, as I mentioned before, dysfunctional beliefs about themselves and others, and their motivation is very low. So when you think about substance use disorder and ADHD, remember that adults with ADHD use substances to manage their symptoms, and substance use disorder makes ADHD symptoms worse. So that's the catch that we're in here. But treating ADHD prevents the worsening of all the comorbidities. So it's not just substance use disorder, but also their co-occurring depression, anxiety, or other things. So it's a very important issue to be paid attention to in our population.
Okay, now what do we have to offer to someone with the ADHD? That is the short-term clinical trials of the pharmacotherapy in adult ADHD shows some efficacy in reducing the symptoms of the ADHD, and also the evidence of the long-term is also shows that some benefit of the using this medication. But also we know that in adult ADHD, we have to combine the pharmacotherapy with the psychotherapy. So it's not something that goes one with another one. And sometimes when the patients are using the correct psychotherapy and learning those skills, they don't have to continue their medication for the rest of their life. Now, when it comes to the treatment of the ADHD, if we make a diagnosis, and also I have to mention that one, that lots of time we do not make an effort when we are treating the patient with the substance use disorder to really diagnose the ADHD part. So that's pretty much, you know, in our fault from the providers, that we don't pay attention to anything else beside the substance use that they came to get the treatment for. And therefore, sometimes, as Mina said, we are getting to this vicious cycle of the substance use is making the ADHD symptoms worse, and ADHD will prevent them from staying away from the use of the substance. So what medication do we have on board in the clinical setting right now in the United States? We have methylphenidate. We have the amphetamine stimulants, including the dextroamphetamine and less dextroamphetamine. And we have these are can be a short and long acting. Those are the stimulants that we can use to treat the patient with ADHD, but we are not limited to the stimulant. We have a non-stimulants medication that if we are not trying to put the patient on any controlled substance, we have the atomoxetine and bupropion and tricyclic antidepressant like desipramine, that those are indicated for the treatment of the ADHD. Alpha-2 adrenergic agonists such as clonidine and guanfacine, those are medication that it's working with the children for the ADHD, but it does not have a good result among the adults. So it's a questionable use of the alpha-2 adrenergic agonist for the adult. But those three medication group that we have, it does show some benefit. Now, what is the problem? The problem is if you give a stimulant, it will affect the patient immediately. It will subside all the symptoms, and it will treat the symptoms immediately in the day that they are using. And I have the slide that is very busy, and later on I will put it there where you can make it a bigger size and look at it, the duration of the action. But when it comes to the atomoxetine and bupropion and tricyclic, when we start, it takes several weeks to show any benefit of the medication. And as you may know, it is the nature of the disease, and they don't have a good, impulsive, at least impulsivity would cause them to give up in the treatment of the atomoxetine and bupropion or tricyclic. So it's very important to educate the patient what is the expectation of the using this medication and how long we have to give time to see any benefit from the medication in order for the increasing the compliance for those medication. And I have seen many patients that they come to me and they said that I use the atomoxetine and it doesn't work. But when you look at it, you say, how long did you use? What was the dose of the medication? It was mainly, a few weeks only. And they didn't give enough time for the medication. And it convincing someone that tried some medication before and it didn't work is harder sometimes. So if you cannot convince them to take it, don't start it. This is a slide that I was talking about. It's a very, I've adopted this one from the up to date, but it does increase the size for you, duration of effect and the initial dose and everything, titration and everything that is you needed for all those medication that is prescribed for the ADHD is listed. And I took this one a few days ago from the up to date. So I'm thinking that it would be still up to date. So you can take a look at it. Now, non-pharmacological.
Okay. Thank you, Kamran. As Kamran said, medication plus psychotherapy is the gold standard treatment for ADHD. This is especially true in the adult, undiagnosed adult population, because they've had years and years of developing bad habits and having the negative consequences of that. So the overarching goal of psychosocial intervention for ADHD in adults is to increase their adaptive functioning, basically help them learn to adult for the first time. That means teaching effective coping skills within every domain of their life. Because remember, this is a disorder that doesn't just affect school. It affects any area where a person has to be organized, motivated, emotionally regulated, which is everything: school, work, relationships. You can deliver the psychosocial interventions either individually or in group. It's pretty efficient to do it in a group setting, but what you're going to do is help patients learn to plan, prioritize, break down tasks. I teach my patients to do something called chunking, which is to chunk tasks together and then take a break. Like tasks are done together. An example would be when you're doing housework, going into every room and throwing out all the trash in every room, and then moving on to cleaning up all the dirty dishes and then moving on. So eliminating the opportunity for distraction. That's what breaking those tasks down does. Using to-do lists, block scheduling, creating routines. Routines are the person with ADHD's friend. The more things that you have in your life that are routine, the less you have to think about it and the less you have to want to, because the routine just kind of takes over for you. Time management, of course, organization, dealing with procrastination and I don't feel like it, using cognitive therapy there. And then dealing with the impulsivity and the emotional dysregulation that comes with ADHD. A lot of patients with ADHD have anger and other emotional dysregulation problems. And most importantly, teaching them how to problem solve. Problem solve is one of the least used coping strategies. And patients with ADHD have not had the attention to learn how to identify and brainstorm solutions, put them into practice and evaluate them. So that's a really big part of what I do with patients. As I said before, there's a lot of comorbid depression with ADHD. And so there are a lot of cognitive distortions and negative core beliefs that lend themselves to cognitive behavioral therapy. And as I said, these can be done individually or in a group setting. Next. I'd like to leave you with this idea. You know, I could talk for hours about how to treat ADHD, but I want you to remember that the main challenge facing us as clinicians is to help adults with ADHD to be able to consistently follow through on the use of the coping strategies that we treat them, despite the fact that it is problems with follow through and other facets of self-regulation that are the very reason that they're in treatment to start with. And that is a challenge. And that's also a challenge in getting them to stay with their recovery plan, is the very thing they need the most as patients with substance use disorder, is to follow through. And their ADHD is the disorder that prevents follow through. So please remember that that is such a challenge in up to a quarter of our patients. And so if we get frustrated, it might serve you well to screen your patients for substance use disorder in order to give them the skills to follow your treatment plan. I wanted to give you a couple of resources in addition just to the references at the end. There's several very good associations, the Attention Deficit Disorder Association and CHAD, which is the Children and Adults with ADHD. They have wonderful websites. And then some recommended reading for you and your patients. The Barkley book, Taking Charge of Adult ADHD, is a great book for patients, and it helps them understand their subtype of ADHD, the nuanced presentations, and gives them some skill building exercises. Gabor Mate's book, Scattered, How Attention Deficit Disorder Originates and What You Can Do About It, is a brilliant read, as any Mate book is. If you want to understand what it's like to have ADHD, I highly recommend that. You may be familiar with Gabor Mate because he's also written the book In the Realm of Hungry Ghosts about people with substance use disorder. And he himself has ADHD. And then finally, a book that gives you basically a whole group's worth of interventions is Ramsey's book, Non-Medication Treatments for Adult ADHD. I really recommend that. It's easy to use. I'll give you some ideas, as well as one that I didn't put on here, and I apologize, it's in the reference list, but it's called Cognitive Behavioral Therapy for Adult ADHD by Mary Salanto. So that will get you started if you're interested in doing some non-pharmacological treatment, and there are our references there.
Fantastic, guys. Thank you so much. That was, I really been wanting a talk on ADHD, and all I had to do was show up for my own echo and I got it. Beautiful. Thank you so much, guys. What questions do we have? And while you're thinking about a question you may have, Rick has been at it again, and he has loads of links, and he even put up the Realm of Hungry Ghosts by Gabor Mate, the Amazon link for that. It is a fabulous book if you haven't read it. I think I may be getting scattered. Thank you, Mina, for that recommendation. But there are a number of articles that Rick has listed for us in the chat as well. And Meredith also let us know that ADHD testing is being offered this summer at ETSU by the clinical psychology doctoral students under the supervision of a licensed psychologist. So that link is in there as well. If you guys want to grab that and save it. As usual, these resources will be pulled at the end of our ECHO session and put onto our resources section underneath our ETSU BMAT ECHO webpage. So there is a treasure trove of goodies in there. So if you don't want to wait for it to show up on the resource page, just copy paste that onto a Word document on your computer. What questions do you guys have?
I did have a quick question. I'm sorry, I did step away from a moment. But is there a hereditary or a genetic component, like where the ADHD is passed down from a parent to a child? Has that been studied? I apologize if I missed it.
Yes, Kelsey, really good question. It is one of the more inheritable mental health disorders. And yes, you will find, I don't have the number in my head right now. Maybe Rick can look that up for us, but there is a connection. And I always ask, does anyone else in your family, siblings or parents have ADHD? It's a good place to start.
Fabulous. Actually, our case is about a patient with ADHD. So I'll go ahead and roll into that unless there are any other questions. Keith, it looks like you're unmuted, so I don't know if you're wanting to pop a question in there. I'll give you a chance if you want to do that right now. Nope, he just put his mute back up. So I'll go ahead and get started with our patient case. I filled out the Survey Monkey form, but I don't have it to share with you guys. We weren't able to grab it. So luckily, it's just right here in my head, so we don't have the form. It's a 29-year-old female. She's been our patient for getting close to a couple of years. She came to us in her 3rd trimester of pregnancy. She was around 32 weeks pregnant. She had, at that time, current use of cocaine and heroin, but she has past history of alcohol, heavy alcohol use, hallucinogens, marijuana, and other opioids as well. She recalls her first exposure to someone using substances being her mother at age 8 and finding her mother passed out from excessive alcohol use. This patient herself did have her first use of alcohol at age 12, and she became drunk with her cousin at that age. And then around 15, 16, in her teens, she started using marijuana daily to help herself go to sleep. She struggled in school. She had a hard time staying in her seat. She had a hard time following through on the tasks that she was given. She also had a rather disordered home life. She is one of, I believe, she's either one of 4 siblings or she has 4 siblings. There are a number of other children in the family. And she, along with her other siblings, did end up in a group home when she was under the age of 18 because parenting was not happening. And so she and her siblings were removed from the home. And when asked what her best experience in life was, like her favorite memory, it was the time that she was in the group home. So some of the things that she was experiencing in school, was it related to another diagnosis? Was it related to a dysregulated home life? Lots of questions there that we could dive into, possibly and pull apart. But from there, she did end up back in the home with this mother who is actually who she's living with currently. She did go on and deliver at term a beautiful little boy who is close to a year old. He was born June of 2020. Leading up to that birth, we did have occasional continued return to use, more of cocaine than opioids. She had stabilized on buprenorphine in that last trimester of her pregnancy. And once the baby came, she was like, that's it, I'm done. She was exclusively breastfeeding. She had consistently negative urine drug screens. The father of the child actually lives in a halfway house in Texas, and we were going great guns and things were really on track for her until he came up for his first visit. And then we had a bit of a faltering with return to use at that time. But through all of this, we have also been working with anxiety, possible anxiety, underlying anxiety disorder, but also talking about her concerns about possibly having ADHD. We did do an ADHD, the symptom list that Mina was referring to. We reviewed that with her and it came back as very positive. I could not find the actual questionnaire that she had filled out, but in one of my notes, it did mention that it was very positive. Also, just to back up a little bit, her PHQ-9 and an Edinburgh postpartum depression scale, both of them were kind of on the mild end, not suggestive of depression requiring medication at either time we administered those questionnaires. Her GAD-7 score came in kind of, again, medium range, but her ACEs, when we did that on intake, her ACEs score was 7. And if you guys remember ACEs, the higher the number of ACEs, the more challenging the outcomes. Also, you can kind of predict likelihood of return to use and multiple episodes of return to use. So she's got an ACEs that certainly supports the track record we've seen with her. But when we started exploring the potential of ADHD and getting her started on medication and knowing that she has history of, and when she has returned to use, it has been again with cocaine. And I think within the last week or two, she has had a single use of cocaine. She was also traveling with that same individual who fathered her child when that happened. But we did explore different avenues. I started her initially on a medication to address the underlying anxiety. That actually tanked her mood. It made her feel more depressed. It certainly did not help with the anxiety. When we did that, I believe it was Lexapro that we had tried. So we came off of that. I had talked to her about using bupropion as a potential ADHD medication, as well as also help with some mood issues, maybe also help with her anxiety. We were in the postpartum realm at this time and she was exclusively breastfeeding. So thinking about putting stimulants into the picture while she was breastfeeding was something we had discussed. She had also purchased Adderall that she would use from time to time, and she would mention that to me and try and help me with my medication choices and direct me towards using that Adderall for her. We eventually got to the point where we did try the methylphenidate, went to a pretty decent, I don't remember what we maxed out at. I don't think we hit the max dose, but we did kind of like, okay, we've given that enough of a trial run and it's done nothing for you, that I did go ahead and say, fine, you told me all along that Adderall was the one that would help. And she is currently on Adderall, an extended release dose. And to be honest, we have seen more improvement now that she is on that medication. She is also on the bupropion, so she's on both. Because we were having some depressed mood, again, it had returned and she actually seems much more organized. Much better mood. She's got a much brighter affect than she had previously. Her engagement with her child is a joy to watch. She's very engaged. She's very responsive to his cues. Just seeing how he interacts with her, you can tell it's not just something she does for us in the office. So the question, which I didn't put at the beginning of what I was saying, is basically, I'll be honest, it gives me pause. And I think, am I doing what I need to be doing by giving stimulants to my patients who have a substance use disorder, which has included the use of stimulants? Am I just giving them a different route of access than the one when they go onto the underground market to get access? Because she has purchased Adderall outside of a pharmacy to do some self-medicating. So that is my clinical question. Am I doing more harm than good? I see my patients and I feel like when I see them doing well, like this particular patient is, although in the past 2 weeks we have had a return to using cocaine, am I doing more harm than good? That is the clinical question. And I'm just curious what others have felt when they've either seen patients with a history of stimulant use disorder who are being prescribed stimulants, others' thoughts and experiences in managing ADHD in our adults with substance use disorder. I see it in my patients and I feel like I'm doing what I'm supposed to be doing, but every single time I do it, and we actually just started another patient today who screened high on the ADHD questionnaire. We started him on methylphenidate today, and I'm always like, when I go to authorize that prescription, I take a deep breath and I'm like, I hope we're making the right choice. So I'd love to hear feedback from you guys on this. But not everyone at once. I can only take one at a time.
Well, I have a question actually. Does she get is she interested to get engaged to the psychotherapy part of it?
She is, and she does. Actually, Mina is the one who introduced me. So when she was describing chunking, I'm like, I totally know what that is. And Mina, confession time, I use it with my kids at home. It works. But the idea of how to tackle the day. So she's very open to the psychosocial interventions of managing her ADHD symptoms. And I think that's part of what this last visit, even though she had a return to use, she seems so much more on it. She uses her planner. She does things, and us also knowing like this diagnosis is there and the guidance that we give her, it's like, okay, transportation has been an issue. I'm going to schedule all your appointments. Here's the NetTrans number, call that number, get them all set up with NetTrans so you know you have access to your visits, making them same day, same time, just so it's easier for her to remember. So it's not just her engaging in some psychosocial interventions, but us supporting psychosocial interventions for her as well. And those things have made a difference. Her consistency with keeping appointments, we were so scattered for a while. We're not anymore. She even, because she was out of town and she called, I'm not going to make it back in time from Connecticut for my appointment. She did that on her own. And that is something that would not have happened 6 months ago.
That was a great thing that you did, Joyce, that when you started putting her appointment at the same time on the same day every week, and then I saw her at the same time every day, every week, I started noticing an improvement in her. Because even before that, we had given her calendars and we tried everything, but she is, in my clinical experience, one of the more severe patients that I've worked with ADHD, and she just couldn't get used to using the calendar. And so we made a lot of progress by making it easier for her.
Yeah, kind of that two-way street approach. Like we can do things to make it less challenging for our patients as well. And I think we were able to find something effective for her, definitely. Brooke, are you guys seeing many people with ADHD in your clinic? Are you guys managing that at all, or is it being referred out?
Yeah, no, we're actually doing that. And I think a lot too here, we have a couple of providers that are nurse practitioners and PAs that see quite a bit that are adolescent or young adults, not, maybe 18 to 23, 24, maybe not as much above 30 or above. But a lot of ours, we have seen a lot more increase probably in about the last year with SUD and MAT, a lot more with the bipolar diagnosis. And I thought that was intriguing on our part because a lot of those diagnoses don't come out until they've been clean for over a year. So I thought that was very interesting. In a couple with the ADHD, they had had a history of it. It had gotten better. They stopped the medication while in high school and they went to college, got through college. And once they got older, we've had a couple in their 40s that once they gotten older and they've had things, situational factors occur, they weren't using or anything like that, that's happened. So, but yeah, ADHD, I agree with you 100%. We do see that, but some of the symptoms are underlying and we don't see it until after they've got their recovery component.
Just kind of echoing what was in the presentation around, there's a whole really long differential diagnosis list, and until we kind of address those type of things, sometimes it can be hard to know exactly what we're dealing with. And actually, Kamran, you kind of did this for me. I'm not used to being the presenter and I can't summarize my own case, but I didn't ask for clarifying questions. Does anybody have clarifying questions for this patient? I'm going out of order. I need routine.
The only other thing I would say too, I think it's really neat that people are in different clinical settings, primary care versus community mental health, outpatient, inpatient, residential. I think that is what makes us all a great team because we all are taught to look for the symptoms and how to diagnose someone. But I think it's really great as a team. We are able to look at the difference in our clinical settings to be able how we need to present and dissect that with the client and educate them. Because not every provider is different. We all get treated and taught the same way, but we internalize and our thought processes are totally different. So I really like that we all can talk about it in different ways, because primary care with integrated behavioral health is a whole new ballgame. And I talk about that because being in that, I mean, I worked in a community mental health center for years, and coming to the substance use disorder and MAT side of it in primary care, I've really learned a lot, especially with the DSM and how to diagnose things. Of course, I'm in grad school too. I can't diagnose right now until I get out, but I'm having those classes and learning. I'm in a psychopharmacology class right now. So what you all talked about today has really educated me on kind of what to look for with the patient's severity. You know, are they mild, moderate, or severe? And I think sometimes we forget too, as a provider, that we can't let that diagnosis define the patient, and we have to educate them on the severity of that rating scale. That's what we're having to look at.
Excellent. No, thank you, Brooke, for pointing that out. The integration of medical care and mental health care is long overdue and incredibly important. So I'm glad you guys are doing it out there too. Michael, you've unmuted, sir.
Yeah, Joyce, I was really pleased to hear you talk about her parenting skills and how well she's responded to being a mother. And I think, again, looking at it from strength base, I mean, as Mina was saying, she's really open to the psychosocial. She must be applying a lot of those skills to that particular situation. I think that's important to reinforce.
It's almost like she's hungry for them. Like she's super hungry. She wants them. She wants to know how to use them. There's a lot of repeating and rewinding and reminding and reinforcing that has to happen. And they talked about it in their presentation, just a lot of the negative input these individuals get and having to kind of work through that and move forward. When we first started talking about this diagnosis, there were buckets and buckets and buckets of negativity about it. Just even current, like her family feeding her messages of how deficient she was, how broken she was, how difficult it was to be around her. And one of her brothers, whom she really feels like she connects to well, but it's an important relationship to her, and it worries her that she's going to screw it up because, you know, she's a screw up, right? That's the message she's been getting. So he was getting ready to be deployed, I think, and she really wanted to talk to him and connect with him, and she was super nervous. And that interplay of substance use and ADHD and being able to stay on topic and keep a conversation going, that's what she was worried about. So she was like, I was really tempted. I was going to have a beer before I called him. So reaching to that substance to help make me more functional, because I see myself more functional when I've taken something else in and not such a screw up. But she's like, I didn't do it. And I had a fabulous conversation with him, and I was 100% present for it. So she's had a lot of positive reinforcing experiences as well, which has really helped. But again, like we see her with pretty good frequency, and it's not because of the opioid use disorder piece that she also represents. She's been on the same dose. She's actually done some self-weaning. It's all this other stuff that we're working on, and why she's having these frequency of appointments is her success in this area means she'll be successful in other areas.
One thing that I think has helped this patient is, and I tease her about this, is I actually have ADHD myself. And so I call myself her peer recovery specialist for ADHD. And the reason why that helps her is that ADHD is very stigmatizing. The functioning with a patient that has severe ADHD is so low, and they're so used to being criticized and so used to having failures, that for her to see somebody that has overcome that diagnosis has really been helpful for her. And we just enjoy spending time together, and we do understand what it's like to be scattered. On the flip side of that, I always try to help my patients see the upside of ADHD. There's a lot of people with ADHD that are highly energetic and highly creative. And the same thing that causes problems with functioning is a gift when you're creative. The ability to switch from one idea to another and to synthesize very quickly, to have the energy to go. So I hope that you'll remember that even though we consider it a disorder, there's always strengths to be found in our patients with ADHD, and they need to hear that.
Definitely. Any other comments or thoughts or clarifying questions? Because I did blow through that. We got some stuff in chat. Hang on, guys. And again, Rick is continuing to put information into chat. So if you grabbed it once and you thought you were good, you may want to go back and look again and make certain you didn't miss stuff, because Rick is busy over there providing us with resources. In 2 weeks, we get together again. Oh, it's the 26th of May. I don't know where this month is going either. April just was a poof and then it was gone. 26th of May, we're getting together and you get to hear more from me. I'm the one who's giving the presentation next time we get together. And I'm going to be going over the syndemics of infectious diseases and substance use disorders. So talking a bit about not just the HIV and hepatitis C happen, but a little bit of how to treat them as well. So please come back in 2 weeks to join us for that talk. And we need a case. We need a case. So think about some cases today, because we knew we were talking about ADHD and we have a number of patients in our practice, in particular the one that I presented today. I went ahead and volunteered to present her to you guys because she exemplifies, I think, very well what Kamran and Mina presented to us today. And especially because she is, we still have a way to go, but she is doing what she needs to do, and she's showing some progress and some success, and I think a little bit of feeling good about herself and her accomplishments, which is nice to see. But so we're thinking about cases. It can be an update on a previous case. It can be something brand new we haven't heard about, someone we have not heard from before, or someone we haven't heard from in a while. So please think about your patients and individuals that you encounter that you have the potential to see again. Could be someone that you saw a year ago and they're on your mind and you want to share that experience with us. So bring those cases to us. I'm going to give you 3 minutes of your life back. We'll see you in 2 weeks, everyone. Thank you. Bye.